Today's topic is about split or shared evaluation and management visits focused on internal emergency medicine. In today's agenda, we will learn the definition and guidelines on split share EM visits based on the recently revised definition provided by the CMS for calendar year 2024. We will also discuss these visits based on MDM to comprehend which provider is credited for the substantive portion performed. Before we start, please do subscribe to the MCL Charge Capture and Coding.com for the latest charge capture and coding newsletter. So welcome everyone to today's training. This presentation is brought to you by your coding teacher, Mai. This serves as a new training for new hires and maybe a recurrent training for existing medical staff. Some of you may feel overwhelmed or confused in coding a split shared encounter and may shy away from coding this type of visit, but always remember that you are not alone. While coding split shared visits might seem like a daunting task, with training and practice, you will soon find that the process is simpler than you might think. We extracted our source for today's training from the CMS website. First on the agenda are definition and the guidelines. So first, what is a split or shared EM visit? Based on CMS calendar year 2024's revised definition, it is an EM visit in a facility setting, such as hospitals and other institutional settings, that is provided in part by an attending and in part by an NPP, or non-physician practitioner, or mid-level provider, or advanced physician practitioner, and they belong in the same group and specialty such that the EM visit could be billed by the physician or the NPP. This means that we determine who bills for the service by looking at the attestation and MDM documentation provided to us for that encounter. Direct or non-direct patient contact requirement. The CMS guidelines dictate that there must be a face-to-face interaction between a provider and the patient. In a split or shared EM visit, this could mean that both the attending physician and the mid-level provider, together at the same time or separately, or just either one of them, must see the patient. It is a requirement. A substantive portion could be entirely with or without direct patient contact, as long as there is one provider who sees the patient. We will then understand that whoever performed the substantive portion bills for the visit. So what is the substantive portion, by the way? The provider who spent more than half of the total time, for hospitalists only, before performing the split or shared visit, or in case of emergency medicine, which is our topic for today, a substantive part of the medical decision-making receives the billing credit. So we look at the attending physician's attestation and the PA or NP's MDM portion of the visit. We compare who provided sufficient documentation for a substantive portion of the service so we can appropriately bill for the visit. In this slide, we summarized what we have just learned from the previous slides. So the correct TPA consisted of a complete 3-section information. So first, there must be a direct or non-direct contact statement. Example, the patient was seen and examined by me with the PA, so that means the attending physician and the PA saw the patient. Or another example is that I discussed the case of the patient with the NPP. This does not state that the attending physician saw the patient, only the NPP did. And second, the TPA must reflect a shared and owned statement assessment. I agree with the history exam medical decision-making documented by the mid-level. Additionally, my history, physical exam, and MDM are as follows. So The first part of this statement is that the attending physician evaluated what the NPP had documented, and then if the attending physician added his own statement, we can use this for evaluating whether or not the attending physician can get the credit, the billing credit. And then the third would be the details of MDM level of service. Example, the attending physician will document the COPA, the data, and the risk under his TPA. In our agenda is focusing on MDM. In the emergency department, we code the level of service based on MDM. Take note on MDM. And guidelines are better understood when we comprehend who gets to bill for the EM visit, especially when both physician and mid-level provider documented complete medical decision-making statements. So this slide summarizes the guidelines in determining who to give the billing credit to. As you can see, Section 1, COPA, Section 2, Data, Category 1, and Section 3, Risk. These are shared between the attending physician and the mid-level provider. So if the mid-level provider had already documented them, the attending physician does not have to redocument the same section. So they both each get credit. But if you can see as well, not shared would be the Category 2 and Category 3. Whoever documented them in their TPA or the MDM portion of the whole chart will get the billing credit. Again, let us make sure that we double check if the TPA provided by the attending physician is complete and correct before we proceed. Because if it is not complete or not correct, we query the provider to make sure. But if it is, we then move on to the MDM. Our deciding factor again is either interpretation or the consult. So whoever documented them gets the billing credit. But if both the attending physician and the mid-level provided documented that the Category 2 or Category 3 of Section 2, we give the billing credit to the attending physician and append a modifier FS. But if it's only the mid-level provider who documented the interpretation or consult, we give credit to the NP or the PA, and we do not append the modifier FS. So remember, Category 2 or 3 dictates who bills for the service if both providers have MDM level of service documentation. So if the attending's TPA contained any of these categories, the interpretation or the consult, we bill the credit of the EM visit to that attending and append the modifier FS to indicate a split shared EM visit. However, again, let me remind you, if it's only the NPP who documented the interpretation or consult, we bill the EM visit to the NPP without appending the FS modifier. So thank you, everyone. That ends our training for today. If you do have any questions, please do not hesitate to contact us at customerservice@mclchargecapture.encoding.com, and we will be happy to reply. The CMS link for more information, and have a great day. We will see you on our next blog for the application of the split share visit in terms of practice examples or practice scenarios. Thank you.